when you take estrogen, it basically protects every system in our body. It reduces inflammation, it improves insulin sensitivity, it protects our bones from osteoporosis, it protects our cardiovascular system from plaque and heart attack, stroke. It protects our brain from Alzheimer's. It protects our eyes from cataracts.
Welcome to Wellness. I'm your host, Ashley Deely. I'm a certified sports nutrition coach, former personal trainer and Pilates instructor, and I have a degree in kinesiology. I'm here to support you in upgrading your life through biohacking. Whichever platform you're streaming this podcast on, it would mean the world to me if you could leave a review, as it helps listeners just like you find this hidden health information faster. America hasn't updated its beauty laws in over 80 years, and the cosmetics industry is highly unregulated, meaning harmful chemicals are hiding in your typical drugstore and big box products. But ARAZA Beauty is the first paleo-certified makeup line in the US, made with real ingredients you can pronounce. No parabens, phthalates, hidden toxins like PUFAs, titanium dioxides, or silicone fillers. Their formulas are nourishing and actually good for your skin. They promote that youthful glow and high performance results. Visit arazabeauty.com/Ashley Deely, ARAZA. That's arazabeauty.com/Ashley Deely. Today's guest is one of my favorite people on the planet. Her name is Rachel Bowers, and she's a physician's assistant with nearly 2 decades of experience across various medical specialties, including urology, endocrinology, internal medicine, neurosurgery, and emergency medicine. She and her sister, Tabitha Simmons, co-founded Halcyon Health, a clinic rooted in science, intuition, and unapologetic advocacy. Rachel is known for her whole body, symptoms-driven approach, and she's one of the top experts in bioidentical hormone replacement therapy. Having experienced her own lifelong hormonal imbalance, bioidentical replacement therapy became Rachel's passion. Rachel and her sister run Halcyon Health in Las Vegas, Nevada, and her sister Tabitha brings structure, strategy, and soul to everything she builds. This dynamic duo is a powerhouse to helping women unlock better, vibrant health. If you've been struggling with mystery symptoms, not sleeping well, irritable, itchy ears, frozen shoulder, or constant UTIs, this episode is for you. Rachel, welcome to the show.
Thank you so much for having me.
Your work is so profound, and I'm so thankful that I came across it. And I've already given listeners a bit of your background, but for people hearing about you for the first time, can you give us a bit of your background story?
Sure, absolutely. So, real quick, my experience, I've been a PA for 20 years. I've practiced in numerous specialties, but many of them have kind of like geared me in, like kind of molded me into the person I am today. And I think that made me the best version of myself for this. So it's been really fortunate that I've had the experiences I've had. And so I also am very passionate about hormones, not just because of what I've done for the last 20 years, but also because I was diagnosed with thyroid dysfunction when I was a teenager, when I was 15. And then I was also diagnosed with pituitary hypofunction when I was in my 30s. And so I've just battled a lot with like fatigue and issues that I think young, because I was much like you, very healthy, exercised every day, ate very well, much better than my peers, and still battled with like the ability to like get up and go and be focused and be motivated and all of that. I had to work really hard. So it was a huge passion of mine, even long before I realized all that I know now. And it's just become even more of a passion since.
Thank you. I like that you had mentioned the best version of yourself, because I feel like that's what we all want to put our face forwards to become.
Yeah.
What was it like being diagnosed, or how did you get diagnosed with a thyroid issue at 15?
Yeah, it was crazy. I just wasn't like, I was falling asleep in class at school, and I would come home and then I would take a 2-hour nap right after school. I was gaining weight. I just felt super tired. It was hard for me to focus. I was a really good student, so doing homework was like incredibly hard. Not because the work was hard, but just like focusing and doing it. My brain didn't seem to want to like fire on all cylinders. So my mom took me to a bunch of doctors, like primary care doctors. Much of them, they told me that I was depressed. They put me on an antidepressant. They told me that I had teenage angst and I needed a therapist. My mom sent me to a therapist. So after about a year of going to like traditional doctors, my mom took me to a homeopath. And within like 5 minutes, he was like, "Oh, your thyroid doesn't work.
Oh,
Let's try some thyroid medication and see what happens." And like within a month, I was like in a different person. I was just like, "Oh my God, like this was the missing piece." But it was crazy. It took a whole year of just feeling horrible. And I mean, not sick. Like I wasn't throwing up or I didn't have a fever or anything. I just didn't feel like I could function. And so much today, especially with women, that is labeled as being normal. Like, oh, you're just a mom, or you work too hard, or, you have 5 kids, or you have, you're stressed out or whatever. Like they give us all of these other excuses for feeling that way. And same thing that happened to me at 15, like a year of doctors just telling me it was something else. And then finally someone doing the right tests and telling me that like, oh, you actually have a problem and this is how we fix it. So it was very difficult, but I'm glad it happened.
yes. Okay. I love the silver lining. And this is why I'm so thankful for your work, because you hit the nail on the head with so many women being told this is normal. Take some antidepressants or your pill of choice,
Right.
until they've come across someone who says, well, let's look at the root cause, which it sounds like that naturopath did.
Yeah.
So what was the catalyst for you to get into all things hormones?
So it kind of stemmed. I was always like, even in school, when I went to med school, I really believed in like what hormones did in the body. Like to me, it seemed like the key to everything when I was learning about that system. And I felt like, although I didn't know if that at the time I was in my 20s, I was like, I don't know if that route of medicine is going to be fulfilling to me. But I thought of that system as being so profoundly important to the body and the way it functions. So it started way back then. And then about 10 years ago, I started working with a urologist, and I was seeing a lot of women with urinary tract infections, like just recurrent. So they would come in, they'd have a UTI. I would treat them with an antibiotic. They'd come back a month later, have another UTI, and treat them with an antibiotic. It was just like so on and so forth. And it just seemed asinine that this was my only tool to treat their urinary tract infection. And so my supervising physician at the time, I did the usual workup, which is like look at the kidneys, make sure there's no kidney stones or kidney dysfunction, look inside the bladder, make sure they don't have some weird anatomic abnormality. And then if all that's normal, then they're like, more antibiotics. And I just thought, and I'm not a big, huge believer in antibiotics unless absolutely necessary. If there's a way that we can prevent the infection to begin with, that saves our body in so many ways, because long courses of antibiotics actually suppress our immune system and then make us more prone to infection again. So it's like this vicious cycle that happens. So it didn't make sense to me to continue to practice medicine that way. So I was talking again to my supervising physician. I said, there has to be a different way. This can't be the only answer to all of the numerous women that come in with this problem. And he was like, yeah, some of the providers recommend using vaginal estrogen as an option to help prevent urinary tract infection. And I was like, vaginal estrogen, like, tell me more about that. And he's like, yeah, it's just a cream. You put it on, like it's supposed to prevent it. It didn't make sense to me. I was like, how can a hormone prevent a bacteria? So I went to a couple conferences where there was this urologist. She was female and she practiced like sexual medicine, and she talked a lot about the vagina and the health of the vagina and what happens when we lose estrogen, and how it's so important for the vagina to be very pH balanced. And when we lose hormones, that balance is disrupted. And then when we don't have a right pH balance, we lose the good microbiome that is really important for prevention of infection. So that good bacteria prevents the bad bacteria from getting up and to the areas where it shouldn't be. And so it's all, connected. And I was like, oh, that really resonated with me. And then I started treating my patients this way and curing women. Like literally, they would go years with not having an infection. And I thought there's more to this hormone thing than this. And I thought, what else is it doing? Like if estrogen can't just be good for the vagina, like what else is it good for? So then I went and did all the further education that I've gotten on bioidentical hormone replacement and what it does for the rest of the body. So that's where it all started.
Oh my gosh, I love that story. And I'm also really curious to hear, who was that urologist that you heard speaking?
Oh, her name is Dr. Rachel Rubin.
Oh, okay,
Yeah.
great. Okay,
Yeah.
well, we'll make sure to put a link to that because anybody who promotes hormones or has education about them is someone that I want to learn more about. Okay,
Yeah.
so that piqued your interest. So you started learning more about estrogen. What else can estrogen do besides help us not get recurrent
Urinary.
UTIs?
Yeah. So that's topical estrogen for the vagina. And that's, like I said, it helps to pH balance the vagina and keep our microbiome healthy. But when you take estrogen orally or systemically, it protects basically in a woman and some in men too. It basically protects every system in our body. It reduces inflammation. It improves insulin sensitivity. It protects our bones from osteoporosis. It protects our cardiovascular system from plaque and heart attack, stroke. It protects our brain from Alzheimer's. It protects our eyes from cataracts. It protects our skin from decreased laxity and integrity. It helps protect our hair and our skin, keeps our hair and our head, from thinning and drying out. It protects our skin from becoming dry and crepey. That's why so many women now are using estrogen on their face to help improve blood flow and collagen production in the skin of their face. So, it's like everywhere you think of a area in the body, and there is some aspect of estrogen that is improving that area. So, in women, it being our dominant hormone, when we lose it, just imagine what kind of havoc starts in the body without it. So,
What kind of havoc starts when we start to lose estrogen?
basically all of those things that I said that it helps, think of the opposite. So when we go through menopause and we lose our estrogen, we start to have increased insulin resistance, which leads to diabetes, increased inflammation, which can lead to plaque deposition in our vessels, achy joints, achy tendons and ligaments. With increased insulin resistance, we start to see insulin resistance in our brain. And that's one of the things that leads to dementia. Another thing is the inflammation and the deposition of plaque in the tiny vessels of our brain can lead to ischemic strokes and dementia due to poor blood flow. So lack of estrogen can lead to osteoporosis, which is, one of those they call like a silent killer because we don't feel it when when we lose bone density, but we do feel it when we break a bone. And those breaks can happen fairly easily with little trauma. So like breaking a rib when you cough, for example. What else? You can then you'll definitely notice more of the signs of aging. So, skin laxity, more wrinkles, your hair thins out, it gets dry, your skin gets dry and crepey, it starts to sag. We are more prone to cataracts without estrogen. The list goes on and on.
So a few weekends ago, I was at a girlfriend's birthday party and I met this 45-year-old woman and we just hit it off and started chatting. She said that she just couldn't lose weight no matter what she did. And so I started having a conversation with her, and then hormones came up and she said, "Oh, I'd be really interested, but they give you cancer." And I said, "No, they don't. I want to put myself in someone's shoes who's hearing about this information for the first time. Does estrogen give us cancer?"
No, it does not. It is a pro-hormone. So much like there's a lot of things in our body where, if we don't have the cancer to begin with, we're doing all of the things that we need to. We're doing our mindfulness practices. We're avoiding processed foods. We're drinking our water, making sure that it's clean water, avoiding plastic bottles. We are exercising and doing all of those things. We are more likely to prevent the formation of any kind of aberrant cells than someone who doesn't do those things, right? So as long as we're doing that, hormones, the only thing that estrogen will do is if you have a tumor that it already exists, and then we give you hormone like estrogen, it could potentially promote growth of that tumor because it already existed. But if you are, say, 49, you stop having period, 50, you haven't had a period for, a year, you start estrogen immediately, estradiol specifically, and you never had any cancer to begin with, that estradiol is not going to give you cancer. You have to have it first. So, all of those lifestyle practices are super important for us to prevent cancer, maintaining our weight and all of those things. You have to, that is important as well, but we're not going to give you cancer by giving you a hormone. You have to already have it. So,
okay. Yeah. Thanks for clearing that up. Yeah. Now, you had mentioned estradiol.
Yes.
Can you tell me what are the different forms of estrogen and how can we take them?
There's synthetic estrogens and then there's a bioidentical estradiol. So your body actually makes estrogen, and then there's 3 different metabolites of estrogen, which is estradiol, estriol, and estrone. And those different things get broken down in the body differently. The most predominant one is the estradiol in our system. So when we take oral estradiol or estradiol patch or estradiol cream, it's a bioidentical, meaning that it is the exact same molecular structure as what your body makes. So your body recognizes it one for one. Synthetic estrogens, which are things like what's in birth control, that's a synthetic estrogen. And also Premarin, which is a really common one that was used years ago for menopausal women. Those, like Premarin specifically, is made from estrogens from a pregnant horse's urine. And then the birth control synthetic estrogens are made in a lab. But those are not bioidentical, meaning their molecular structure is similar to what our body makes, but not the same, not exactly one for one. So the body doesn't actually know exactly what to do with that. So the metabolites that are broken down from there can be more harmful. Whereas the estradiol, when you swallow it, the metabolites that are broken down from estradiol swallowed are actually beneficial to our heart and cardiovascular system. If you don't swallow estradiol, you don't get those cardiovascular benefits. Topical estrogen and estradiol in a patch or a cream, injection estradiol, and estradiol pellet, although those are very beneficial, and I believe that some is better than none, those things don't give us the benefit of cardiovascular protection as much as swallowing it will. So I just mentioned all the different ways that you can get estrogen. So cream, topically, patch, gel, pellet, and then oral tablet.
Out of all of those different bioavailable mechanisms, which one is the most efficacious?
So I would say the oral, because you get that cardiovascular benefit. You get all of the other ones that I mentioned, like the brain, the bone, the breast protection, the skin protection, eyes, all of the different body parts. And then you also get that cardiovascular protection. And then I think that when it comes to commercial pharmacy, like CVS, Walgreens versus a compounded pharmacy, that is very individual. I think that the commercial estradiol it is bioidentical. It's not, but it has to have a longer shelf life. It's made for the masses, right? So it has to have preservatives, and there's different binders and what they call excipients within the pill that you can have a reaction to, like nausea or rash or headache or various things. So if you are with a doctor and you're getting that, you're like, I'm on that estradiol, but I don't feel like I should, like she's telling me I should, then you might try a compounded form, because that's made specifically for you. You can create whatever dose you want. If you want 0.25 milligrams or you want 0.7 milligrams, you can create it to match the person. And then within that pill is just pure estradiol. They're going to have one kind of stabilizer in there, plus the veggie cap, and that's pretty much it. So you're not going to get all those excipients that can potentially cause nausea or headache or stomach upset, rash, or anything else.
Rachel, I'm curious. My physician put me on Biest, which is a mixture of estradiol and estriol. And she even told me she didn't want me taking just estradiol. So if my doctor were to listen to this episode, why would you recommend, or what would be the reasoning behind just estradiol?
So estriol is considered a weaker hormone, and it once get into the system, it just gets broken down, and we don't get as much of the benefit as we do with estradiol. So the studies haven't shown. Plus, the other kind of practical reason is it's way more expensive than estradiol as well. So it when if we were going to be prescribing oral or topical estriol, it would be more cost prohibitive for patients than it is estradiol. But that's like a minor reason. A more important one is that it is just not as strong or as beneficial as estradiol alone. They studied estriol for topically for the face and for the vagina. And so I do prescribe estriol for the facial application for patients who want to use to help improve collagen production in their facial skin. But otherwise, I pretty much avoid estriol altogether. And anecdotally, I have used both for like vaginal protection, lubrication, improved pH and microbiome. And I just get far better results with estradiol than I do with estriol. And so mixing it up doesn't provide any added benefit for the individual. It's going to add more cost, which sometimes is like the prohibiting factor for a lot of people. So I'd rather find something that's affordable and they're going to get some than none at all. So that's part of it. It's a very old way of thinking, like a traditional way of thinking when it comes to topical bioidentical hormones. A lot of times people are taught that the only way to be bioidentical is to be like topical, to have a cream, and that if you're taking a pill, it's not bioidentical, but that's not actually true. It has to do with the molecular makeup of the hormone. So if you're getting estradiol, and that's what it says on your prescription, you're getting a bioidentical hormone. So there are different societies out there that train providers on how to prescribe hormones and what to use and what doses and what forms of that hormone to use. And some of them are still very much into using the combo, thinking that some even will use estrone, which is that third estradiol or third estrogen form. And I don't know of any benefit. That just gets your body just kind of metabolizes that out. It doesn't really use it a whole lot. And so you actually it goes into the gut and your body metabolizes it, either poops it out or reabsorbs and then utilizes it in a different way. So it's not a super beneficial hormone, but there's still a lot of doctors out there that believe that you have to get all three in order for you to have the benefit. But in terms of research, estradiol is the number one estrogen that has been studied that has shown benefit.
So glad you're here, Rachel. I also thought that if you took estrogen orally, that it could increase the chances for a blood clot.
So that's actually not true. 20 years ago, there was this big, huge study. It was like 10,000 women. It was called the Women's Health Initiative. And it was initiated because there was a standard of care. All these women after the age of 50 got hormones for menopause. And so the National Institutes of Health decided to say, well, we do this, but is it appropriate? Is it actually something that we should be doing? And so they did this study. They created this huge study. Well, it was really flawed. They didn't study estradiol, which was the main prescription that was being prescribed at the time. They used Premarin. And then they chose patients that were asymptomatic. So they had no symptoms of menopause. And they were between the ages of 65 and 78. So at that age, you were already at greater risk for blood clot, stroke, breast cancer, heart attack, all of those things. So just naturally because of your age. So they took these women already predisposed. They were actually, from what I have heard recently, they weren't very healthy. A lot of them smoked. So there was that on top of it. So they took these women and then they gave them a synthetic estrogen. And they gave them a synthetic progesterone. And they did a progestin is really what it is. progestin arm, which was medroxyprogesterone or Provera. They did the estrogen arm, which was Premarin. And then they did a combo arm, which was, I think this was 4. They did a combo arm, which was Premarin and Provera. And then they did a 4th one that was placebo. And they compared everybody. And Premarin did show if you started and this was the age of the patients, if you started Premarin greater than 10 years after you went through menopause, you had a slight increased risk of blood clot. But if you use estradiol, there is no increased risk for blood clot. Bioidentical matters.
Thank you. Oh my gosh, I feel like that's such a good tagline. Bioidentical matters. Because one of my missions is to get women off birth control, because one of the fun facts that I learned about birth control was that it takes your testosterone down to 0. And at first I thought, well, that's fine. I'm not a man, so I don't care. But it seems like the more research I do, Rachel, testosterone is important for women.
Yeah, it's hugely important. We actually, even though I said like estrogens are a dominant hormone, that's not actually true. Testosterone is. When you check on your lab slip, you get these numbers, right? And your estrogen might say, 300, and your testosterone might say 22. And so you're thinking like, oh, I make way more estrogen than I do testosterone. But what you're not paying attention to are the units of measure. So if you make all units of measure equal, we actually make more testosterone than we do estrogen. And testosterone generally in our cycle is really flat. It doesn't fluctuate much at all. While as estrogen goes up and down. You have periods of your month where your estrogen level is like really low, like say 50, and then other times where it might be 400. So it's highly variable. But at any given time, we do make more testosterone than we do estrogen. That's why it's so important. And crazy that there's no FDA approved testosterone for women, because it's a vital hormone for us. And it's hugely important. They're starting to look into it for athletes, because there's a lot of women who are competitive athletes who are on birth control to manage their cycle for competitions, and their testosterone levels are in the toilet. And but they're not allowed to supplement their testosterone, because then it's illegal in terms of the competitive rules. So it's a tough, but then if you have a woman that's like has a crazy cycle, they're nauseous, they're heavy bleeding, they're tired, whatever, then it's harder for them to compete because their cycles are affecting training as well. So it's a crazy conundrum, at least for that particular population. But testosterone is more important than just for sex. It's more important than just, how good is my libido and how easily can I have an orgasm. It's also very important for our vaginas, hugely important, even as much as estrogen. It's also very important for our muscles. So as women, as we age, it is more and more important for us to build and maintain muscle. And if we don't have a testosterone, it's very difficult. So very important for that. It's also very important for our brain, as it is for men. It is one of the hormones that helps us to have that sense of vitality and vigor. It also helps with motivation, prevents depression. So it's all over the body. It's super important. So yeah, we can't diminish the importance of testosterone in women. Just as important for women as it is for men.
I'm really glad we're talking about testosterone, because I had heard on another podcast that this woman started using it topically, and she said her orgasm strength came back really strong. And I feel like if more people knew that, they would want to be on it, because I think when we think of aging, we think of wrinkles, maybe you don't have sex anymore and you get gray hair. And if you don't have sex anymore, what's the point of living?
Yeah, I know. It is. It's like, I can't tell you how many women come to me because, like in my urology practice, many of my women are, postmenopausal 65 or older. They've told me they haven't had sex in like 10 plus years, and that's just normal. They're at that age. They just don't need to have sex anymore. And I think I find that to be very sad, because I think part of that is a society driven belief, but But I also think part of that is that nobody is helping them to support the hormones that they need in order to have any kind of sex drive, or to have pleasurable sex. Like one of the, vaginal estrogen or vaginal testosterone is hugely important to prevent pain with intercourse. Who wants to have sex if it hurts every time? I don't. And so that's a big driving factor for a lot of women too. They stop because it hurts, and nobody's been able to help them figure out a way to make it not hurt. And so, which is asinine, but that's what happens.
Or they potentially tell them, well, just use lube, just use a lot of lube.
Yeah. And it doesn't. So it doesn't do anything. So lubrication, helps to make things slippery. But one of the things that our vaginas are known for is the ability to stretch, to deliver babies, to accommodate, a penis. And one thing that happens when we lose estrogen and testosterone is our tissues become thin and dry and stiff. So instead of stretching to accommodate whatever we're doing, they tear. So just think it's like a ripping, burning, tearing sensation every time you have intercourse. So not fun. At least I wouldn't think so.
No. I feel like if a man went in to a doctor and said, it hurts to have sex, they would find the root cause. Whereas women, it's kind of like, have you tried a topical recommendation?
Or sometimes it's like, oh, you need to just like focus more on foreplay. And you're like, you don't think I've tried all of that? I mean, it's pretty crazy, the suggestions that I hear. Oh, have a glass of wine, that'll relax you. Or, if their libido is low, they've been told to buy new lingerie. I've had patients tell me that. It's like, how's that going to help me? Like, my lingerie doesn't help me have a better libido. Maybe my husband, but not me. So it's really crazy. So yeah, it's more than just like having a libido and wanting. It's, is it comfortable? Is it pleasurable? Does it hurt? And what sort of things have we done to help improve those things for each individual?
And are we in the right mind frame? And how's our stress? And how are we sleeping? Because I imagine if we're not sleeping well, then maybe we don't want to have sex.
Oh yeah, libido, especially in women. Well, I tell this to my male patients too. When it comes to like erectile function, it's multifactorial. It's not just like how good is the blood flow, which most men think about. It's like, well, what are your hormone levels? How good is the blood flow? Because that's a really important factor. What kind of neurologic state are you in? So like, what I'm talking about there is like, are you diabetic? Are your blood sugars controlled? Because that affects our nerves. And if the nerves cannot transmit those messages appropriately, you're not going to be able to get a good erection. If you've had like multiple back surgeries, or say you're 75 and you've had a stroke, like that brain to penis communication is just not going to be the same. And then there's psychogenic, which is probably the most common and difficult to treat, because that means you've got to think about your, it's performance anxiety, it's stress of the job, or stress of the home, it's anxiety, it's whatever else might be going on, being self-conscious or whatever else. So there's more, and the same things go for women. We have very similar. If we're not getting good blood flow, if we're not going to become lubricated or have the same sensation. If we aren't, we won't have an orgasm. There's no good blood flow either. It has to do with our hormone levels, extremely important. Also our state of mind. So psychogenic really plays a huge role in women and whether or not they're interested in sex, or again, having any kind of sort of pleasure associated with it.
Rachel, one of the reasons I wanted to have you on my show is because we're talking about hormones today. I feel like maybe a lot of people are associated women who are 50 years or older. Mm-hmm. But my personal story is that when I was 37, I started to feel like I was going crazy. I was waking up between 1 and 3 in the morning, and I had always been a perfect sleeper. And I remember walking to the gym one day, listening to 50 Cent, trying to pump myself up, and all I could do was cry. And I was like, I didn't know what was wrong with me. And I was like, I'm the healthiest person I know. I'm a former personal trainer, Pilates instructor. I listen to podcasts like it's my job. Until one day I heard the word perimenopause. And
Mhm.
I felt such relief that I had finally found a word for my symptoms. So, speaking of hormones, what age do we start to lose our hormones?
So that's highly variable, and it depends on each individual situation. So I would say for an average woman who has never had any kind of surgery of any kind, um, or cancer or chemo or radiation, it's going to be somewhere in your 40s is when, well, that's going to be the average, okay? About 40, because the average age of menopause is 52. So 10 years prior to that is when typically when perimenopause starts. So that's 42. But again, we see perimenopause starting as early as 35. I've seen it even younger than that. So, you know, I don't even like to give an age range because if you are experiencing any kind of abnormalities that are not usual for you in terms of how you feel and how you're functioning, I think this, examining your hormones is an important step, or at least talking to someone who understands them and can listen to you in a way from a hormonal perspective to understand whether or not you're somebody that just needs hormonal support. Because one thing that is misunderstood is that blood work doesn't always tell us what needs to happen, right? So if you're someone, so say, like, I don't know your entire story, but say at 37, you started having, you didn't feel like yourself, you were feeling crazy, but you were having periods like clockwork every month, no change. So you're going to go to a gynecologist and they're going to say, I don't need to check your hormones. You're having periods. Everything's fine, right? Um, and so when we're having periods, if we are having periods, typically our ovaries are doing their job, right? They're at least producing enough hormone to allow for ovulation and the fluctuations necessary to have a cycle. But that doesn't mean that they aren't declining. So and that's when we start to feel the changes, is this decline, specifically in our progesterone. That's usually what goes first. That makes us feel so out of whack. And every day of your cycle, your progesterone and your estrogen is different. So it's very difficult. There's if we test you between days 19 and 21, we can kind of get an idea of where you should be. But that's assuming your cycle is perfect and follows the typical rules. But nobody follows the rules, right? We are individuals. Nobody, when we were created as humans, it wasn't like God or the universe, whoever created us, said, okay, the cycle is 28 days and you're going to have your period on day 1 and you're going to ovulate on day 14 and then you're going to, there is none of that. The period ranges from 21 days to 35 days. And so you're the cycle, right? And so who knows where you are? You might say, well, my period tends to be every 28 days, but does that mean you ovulate every time on day 14? Like, I don't, it's just asinine to believe that we can predict those things. My whole point in giving you all of this is that it's so important to listen to the person, to understand what the hormones do in our body, what kind of sensations we feel when we're too low or too high, and then being able to talk to the person and say, well, based on what you're telling me, lack of sleep, irritability, anxiety, depression, irregular cycles, that tells me that you're not getting enough progesterone. Why don't we try supplementing your progesterone to start and see what happens? Because I don't really care. It's not going to mess up your cycle or put you into menopause early or anything like that, or suppress your ovaries like birth control does. It's just going to help to support what your body is no longer able to do for you. So give them a little progesterone, you see how they feel. Oftentimes the anxiety goes away, they sleep much better. That improves their depression and their energy because they're getting sound and restorative sleep. And we fix the person, right? And a simple discussion with that person, which a lot of unfortunately doctors don't do.
You paint such a great picture. If only I'd heard about your work 3 years ago. You mentioned progesterone. What does progesterone do, Rachel?
So progesterone is our feel-good hormone. It's also highly protective for so many systems in our body. So progesterone is protecting our uterus from uterine cancer and endometrial cancer. It's protecting us from ovarian cancer and breast cancer. And it's also helping to prevent us from developing plaque formation in our vessels, have excess cholesterol, or if we have excess exposure to reactive oxygen species, oxidative stress, and things like that. So it's very protective. It also is converted into different downstream hormones called allopregnenolone and allopregnenolone, which are really important for brain function. And they interact with our GABA receptors, which is a neurochemical in our brain. And so that's why when we take progesterone, we have improved anxiety, better sleep, decreased depression, more mood stability. We also have more resilience against stress. So it's not like we are immune to it. It's just now we can tolerate a little bit more without feeling like we're going to break down. So super important for that part of us as women. And it's in perimenopause, it's the first one to go. So we're still making it, but we're just not making quite enough to balance out how the irregularity of our estrogen and also the how much estrogen we have. And so that's why supplementing that in perimenopause is so helpful, because we're just balancing us a little bit better.
That was going to be one of my questions. Out of these three hormones, which one would you typically recommend someone starts with first?
Yeah, so progesterone is my favorite to start with, depending on what their concerns are. But generally speaking, I would say progesterone is what most women need initially. And then like my favorite in perimenopause is progesterone and testosterone, because those are the ones that are declining the most. And, our estrogen is still, our ovaries are still pumping that out pretty well. And most likely in perimenopause, we're still having periods. And so I don't want to add to the already highly variable estrogen levels that we have by giving you estrogen in that volatile state. So I just want to balance the estrogen we're already making by giving you the progesterone. And sometimes in women who have a lot of night sweats and hot flashes, when they're sleeping, progesterone won't do all of it. A lot of doctors, because estrogen is typically known for preventing the hot flashes, they'll want to give a perimenopausal woman a little bit of estrogen to help them with their night sweats and hot flashes. But what actually works better in a perimenopausal woman is testosterone for that. So I'll add on, even if they're not complaining of libido issues, but their high night sweats are like being resistant to the amount of progesterone we're giving them, I'll add in testosterone, and that'll improve their sleep even further and take away any night sweats or hot flashes.
Oh my gosh, I'm learning so much today. Do you think if I'm having regular periods and I'm almost 40 that I don't need estrogen?
That would be my assumption at this point, not knowing like any details about you. That would be my assumption, but it also depends on the dose of what you're getting. So like, for example, estriol, I mentioned, a lot of women want to use that for their face, and that they have done some small studies and have shown that it doesn't absorb systemically. It only gives you local improvement. So you don't get changes in your estrogen levels in terms of your blood when you place it topically at the doses that we give for the skin. So depending on the dose that they're giving you of the biest combination, it may be so tiny that you're not seeing. If it's giving you symptomatic improvement, it may be fine, as long as it's not adding to the already the amount of estrogen that you're making right now.
I just want to now go back to sleep and testosterone, because I took progesterone to help me sleep and it worked really well. But now it sounds like testosterone has a superpower of helping us sleep.
Yeah. It's amazing for men, actually. Like, men can't take progesterone. So when they come in complaining of poor sleep and anxiety, typically for them, that's what it is. It's not enough testosterone. So So it does very similar things for women. And it just gives you that additive benefit that you get from in terms of sleep with progesterone.
So you need to take these together, progesterone and testosterone?
Not at the same time, but they can amplify your benefits. So it's not, you don't have to take it, but if, like I said, if you're having somebody that is like, they're, say you're on 200 or maybe even 400 milligrams of progesterone and you're still having breakthrough night sweats here and there, then I'll make sure that their testosterone is optimal, because oftentimes when that's optimal, then all of those nighttime things get better without having to change the progesterone any further.
Okay. So I have so many more questions, but I have two follow-up questions just to that. What is optimal testosterone for women? Are you looking at free, total, both?
I look at both. The free testosterone is more important. So the range for women is, I think, 0.2 to 5. The level doesn't really matter that much. I mean, I know a lot of doctors really want to focus on numbers, but I don't really care. I want you to feel good. So I want you to have the benefit. I want you to have good libido. I want you to feel strong. I want you to have a good recovery from the gym. I want you to have stamina when you're exercising. I want you to have good orgasms. I want your vagina to be nice and lubricated and without pain. That's what I want, right? So if I give you, say I get your free testosterone to 5, that's the upper limit of normal, and you're still having that dry vagina, you're still having, you're not noticing any improvement in your strength or stamina, you're still very sore after your workouts, I'm going to go up. Whatever your dose is, it's going to be more. So even though that level looks fine, I want to listen to the person. It's a combination of, are you absorbing it? Let me see what your level is to see if this form that we're giving you is working. And then how do you feel? Because that's going to supersede what the number is. I want you to feel good. And then if the number happens to be 20 and that's where you start to feel good, then that's where we stay.
Okay. Earlier you had said there's no FDA approved form of testosterone for women. How do we get testosterone?
Yeah. So there's a few ways. My favorite way is vaginal. So compounded cream that you apply vaginally, like to the inner labia. And because it's pH balancing, we have androgen receptors there. It improves lubrication. And the labia it's kind of like the inside of our mouth, like your cheek, inside of your cheek. When you put something there, it absorbs straight into the bloodstream very quickly, because of the type of tissue it is. When you apply it to like your arm or your thigh, that tissue, that skin is very different. There's more layers for it to go through. It's not as readily available to the bloodstream in that area as compared to the vagina. The other thing is that in the labia, we're chock full of this particular enzyme, and it's escaping me at the moment, converts the testosterone to DHT, which is what they have found is going to be one of the main components for muscle building. So we want to have more DHT. It's a controversial thing because DHT is also the hormone that's known to cause hair loss. And so, men, so the same thing, like women apply to the labia, men, if they apply it to the scrotum, they'll get that same benefit with the DHT. And so if they're concerned about thinning hair or whatever, they'll be really worried about, having too much DHT. And then those people want to take a DHT blocker, things like finasteride or dutasteride, to block the follicles so they can keep their hair. But unfortunately, with those medications, it doesn't just block it at the hair level, it blocks it everywhere. So then you don't get the other benefits of that DHT. You still get DHT when you apply it anywhere else or when you inject it or whatever. It's just not quite as much. So that's the benefit of applying it to the vagina or to the scrotum. But if that doesn't work, you can also apply it to the skin. The dosing has to be adjusted again because the absorption is different. Or it can be injected. You can do subcutaneous injection. That's not really an FDA approved way, even for men. although it works just as well as doing intramuscular injection. When you do subcutaneously, you can do tinier doses more frequently. So depending on how you respond to it, some people like to take smaller doses more often to make their level a little more flatter, not as up and down when they're doing injections. So that would be the benefit of doing it sub-Q. There are oral tablets of testosterone available now on the market. I rarely prescribe them because they're extremely expensive. The other thing is that they, I just recently learned that one of the ways these pills work is they lower something called our sex hormone binding globulin. So the less sex hormone binding globulin we have, the more free testosterone we have. And so that's one of the mechanisms of action. They're just like lowering that protein to have you so that you have more free testosterone. But what people are missing in that scenario is that sex hormone binding globulin is very protective. The higher sex hormone binding globulin we have, the greater protection we have against future insulin resistance and potential diabetes, as well as cancer. So you actually want to have a much higher sex hormone binding globulin, but there's this idea because it binds to our testosterone and makes it inactive that that's a bad thing. Well, if you're giving testosterone, you could just give a little more. You can get both benefits. You can have more testosterone, but also have a high sex hormone binding globulin, which is protected. So,
okay.
Long story short, I don't like the pills.
Okay. Is testosterone a stimulant? Can we take it at night when we take our progesterone?
No, I don't consider it a stimulant. Everybody is different. You kind of have to see how you feel. Some men feel like they get energized after they take it, but I don't think it works that quickly to really feel like it's like a shot of coffee or espresso. So I've taken I actually use the cream and I apply it at night, and it doesn't interfere with my sleep or anything. I mostly do that because when I apply it vaginally, I want to have it sit there and absorb for at least 2 hours before I urinate or wipe it away. So at night, I'm less likely to do that than I am during the day. Okay. And same thing for men when they apply it to the scrotum.
Now, if we decide that we want to take testosterone, do we need to take it every day?
If you're doing it topically, yes. It only stays in our system for 24 hours. So if you were to do it every other day, you wouldn't have any testosterone. it would just fluctuate. When you do an injection, so what I do, so I didn't really answer your question before with respect to the testosterone in terms of the injections. So injections, you can prescribe the male form of testosterone injection to a woman, but we just take like a 10th of the dose. So a typical like average dose for a man is 200 milligrams per week, which is 1 milliliter. For a woman, they would do the same exact thing. They would just drop 0.1 milliliter, so 10 units, tiny, tiny, tiny amount, and they would do that once a week. So in that case, you only do it once a week. You don't need to do it every day. And again, it really depends on how quickly you metabolize it. Women metabolize testosterone much slower than men do. So some men, when they do injections, they can't make it that whole 7 days until their next injection. They feel like a real slump and they're weak. And so those patients, I will have them cut it in half and take it twice a week. And that will help to eliminate that slump.
Now I want to ask you, but I'm going to share a story first about progesterone. So when I first got prescribed progesterone and I started sleeping well, I was like, this is amazing. And I took it every day because I was working with a clinician who didn't know much about hormones. And then I started spotting at very random times throughout my cycles. Then I had to do more research. And then I realized you don't need progesterone every day. So when should we be taking it?
So it really depends. If you're somebody that is sensitive to the progesterone in that way, where you start taking it every day and you do have breakthrough bleeding, then cycling it, and you would cycle it. Usually it's between days 12 to 26. So those are the days that you take it, and then 27, 28 you don't take it, and then 1 through 11 you don't take it. So you have to be somebody that's willing to calendar your cycle and know what days are what. So it's hard for some people to remember that and like figure out what days they're supposed to be, and especially if they already have really irregular cycles. It's really hard for women to cycle it when they don't know. So some doctors will say, well, 2 weeks on, 2 weeks off, and then that way they don't have to like, but then if your cycle is off, then you're having progesterone when you're not necessarily wanting it in your cycle. So it's a tough one. So I generally tell my patients, because again, like every individual is different depending on where your cycle is. If you're like, I was a 28 dayer, I've had patients that are 23 dayers. I've had patients with 35 dayers. So like where, it's hard to determine what weeks you should be taking it based on what typically is necessary for your cycle. So that's why I don't love the cycling way. But because that breakthrough bleeding is really annoying for some women, if you feel like you can do it in a way that's like kind of systematic, then I think it's okay. But I would say like the majority of my patients, I have them just take it every day. There is a small percentage of women that will have breakthrough bleeding the first 6 to 9 months, and then that goes away typically. So it is annoying if you're one of those. Like I started it when I was probably 40, and I never had any breakthrough bleeding unless I forgot to take it, and then I would. But I never had it. I took it perfect the whole time. My sister started, and she was one of those who would have like bleeding every 2 weeks. Oh. And that was really frustrating for her. So, just really depends on the person. So yeah, I don't love the cycling way. I don't think that that's bad or necessarily wrong, but I do find doing it daily is easier.
You use progesterone if you feel so stressed. You're slammed at work, your kids are making you crazy, and you're like, oh my gosh, I need to relax a bit. Does it work kind of as an anti-anxiety?
Not like, I wouldn't say in like that moment, not like that. But I will tell you that there are some women who have like when they're still menstruating, they know that there are like 3 or 4 days of their cycle where it's very difficult for them. And so those days, they will, every month, they will double their progesterone. So they can get through those more difficult days much easier with more. Or if they know like their first 2 days of their cycle is extremely heavy, and it's just like they're anemic, they go through like they can barely leave the house because they just go through so many pads and tampons and whatever. Oftentimes we'll have them double their progesterone like 2 days to a week prior to their period, and then once they get through those first 2 days, then they go back to their regular dose. So there is a way to fluctuate how much you give yourself, but in terms of like, oh, I'm anxious today, I'm going to take an extra one, I don't know that it works really for that. Yeah.
And do you prefer pill form, topical?
If you want to get the sleep benefit for progesterone, you have to swallow it, because you don't get those metabolites of pregnenolone and allopregnenolone for the brain if you don't swallow it. There's something called, and this is the same thing with estrogen, there's something called first pass effect, which happens to all drugs when you swallow it. So you swallow it, it gets into the stomach, it gets absorbed, and it immediately gets shunted to the liver, where it then gets metabolized into its different metabolites. When you put something topically, it goes straight into the bloodstream. You don't get that stomach to liver process that you do with topical injectable pellet forms. So there are some women, it's probably 10% of women are highly sensitive to progesterone. It's typically women that are like, that had like hated pregnancy, felt horrible the whole time. Those women are usually sensitive to progesterone. And so when they swallow it, they don't feel the good stuff. They don't get the sleep. They actually feel more anxious. They sleep worse. They don't feel good. And so those women will do better when you use like a sublingual under the tongue type of thing. So again, you're not getting the first pass. but they're at least getting the protection with your bones, your breasts, your uterus, your ovaries, all of that. Or they can do like a vaginal suppository to bypass some of that so that they don't get those sensitivities. And I do think that sensitivity kind of changes as you get older. You're more sensitive when you're younger and then less when you're older. So someone who needs like a troche or a sublingual tablet or a vaginal suppository when they're real young, when they hit 50 or 55, they can swallow it after that. So it just kind of depends on the individual.
I like the idea of a suppository. I feel like we need a testosterone suppository.
Testosterone could be made that way. That's so nice about compounding is you can make it in pretty much any form that you want it. So it just depends on the person.
Oh, I love that. What a great idea. It just came to me. Okay. What if you are menopausal? What if you are 65, 75 years old? Can you take progesterone every day?
Oh, yeah, absolutely. It's encouraged. You want to have that protection all the time. You don't want to have it only half the month, right? So,
okay.
All the time.
Okay. And is there a certain amount? I heard you, I think maybe earlier, say between 200 and 400 milligrams. I'm sure we're all an N of 1, but do you have a dosage that you like to start out at?
Yeah, I usually start at 100 milligrams because when I have a patient that's sensitive, it doesn't feel good, right? And so I don't want to like blast them with a bunch of progesterone if they're going to be a sensitive person. And I don't know that to begin with. So I usually start with 100. And then if they're tolerating that well and without any issues, then after about 2 to 4 weeks, then we'll bump it up to 200. That's usually like my baseline dose that I like most women to be on. Progesterone, you have to, if you're taking estrogen, you have to be on progesterone because estrogen stimulates your endometrium. And if you don't have that progesterone to balance out that endometrial stimulus, you can cause endometrial hyperplasia, which when persistent can cause endometrial dysplasia, which is a precursor to cancer. So we have to balance the estrogen with the progesterone. So if a woman is 75 and they have a uterus still, even though they're not having periods, they have to take progesterone if they want the estrogen. Now, if they don't want estrogen, you can take progesterone alone. There's no problem with that. But if they want to take estrogen, they absolutely need the progesterone.
Thank you for sharing that tidbit. I really appreciate it because I feel like when we get excited or we start biohacking and we want to take these things into our own hands, it can be deleterious if you don't know what you're doing. And a few months ago, I went to visit my husband in London. We're doing long distance, and I was feeling extra stressed out. And I just wanted to feel better, which I probably should have taken more progesterone, but I was just dumping on the estrogen. And then I only had a 23-day cycle. And I'm guessing it's because I kind of sped up that cycle.
Yeah, you did. Because it'll promote the bleeding. When someone has too much estrogen, the typical symptoms are the 5 B's. So bleeding, bloating, blemishes, bitchiness, and breast tenderness. So that's, so when you have somebody that is like, doesn't have enough progesterone, that's why they get so irritable because they have more estrogen than they do the progesterone. So if you ever notice that you get, you feel bloated or you have your period comes early or you're noticing you're breaking out or your boobs really are sore more so that month than the other, if you were using more of the cream, that might be why.
Can foods like soy make it worse?
I don't think so personally. I'm not one of those people that believes that soy is a problem or like for men or women that like if you're vegan and you eat a bunch of tofu that you're going to become a soy boy or whatever. I don't believe that. I think in some women who, in the past when women would go through menopause naturally, soy could because of the products that are in there that it can help to improve some of the symptoms that are associated with menopause, like the hot flashes and the night sweats. But I don't think that it's bad for us.
I've actually heard that Japanese women have an easier time going through menopause because they do consume more soy
Yeah,
than us.
most likely.
If we wanted to get our estrogen tested, do you prefer blood, urine, or saliva?
Blood. Yeah, predominantly for those hormones I do. It's tough. There's like the Dutch test that a lot of people really like. Um, I personally have not found that to be super helpful in my practice. I recently listened to a lecture by the guy that created that test, and he went through all of the things and what it does and what all the different metabolites mean. And because it's basically a test of metabolites, it's not really necessarily a test of the hormone, the whole hormone. It's the breakdown pieces. Where I think that might be helpful is if you have somebody that is definitely menopausal and they're having symptoms that you would not expect with the appropriate replacement, then I think figuring out where their metabolites are and kind of what pathways their hormone is going down. Because like if they're B12 deficient, or if they need more fish oil, or usually it's a supplement issue, or if their gut is messed up, fixing those things will then help the hormone that they're getting to work better for them. So that's kind of where I find that, and that's a urine test.
I really liked the Dutch test, but I feel like you're teaching me so many things today.
I think it can be helpful. I don't know that it's absolutely necessary. It's very expensive. And you know, I have an agreement with Quest and with my practice, and like a estradiol test costs like $5. You know, it's very affordable, very accessible to most everybody. And whereas the Dutch test costs somewhere between, I don't know, $300 and $400. And so, you know, not accessible to most people. And I don't think it's absolutely necessary. But if I'm really stuck with someone and things that I would expect to happen aren't happening, then I think utilizing other tests like that can be helpful.
I have also heard when it comes to hormones, it's really about how you feel and what your symptoms are. What are some of the top symptoms when it comes to out of balanced hormones?
Hot flashes, night sweats, weight gain, irritability, hair loss is another one, irregular cycles. Those are probably really common. But some less common ones are going to be the anxiety is a huge one that a lot of women have. Skin irritation. So a lot of women will start to have irregular itching, like there's no rash or anything, but they just itch everywhere. That's another one that a lot of people have. Decreased libido, changes in the vaginal tissues, vaginal dryness, vaginal pain, increased urinary tract infections. Irregular bleeding, pain, changes in your cycle in general. So more pain, more bleeding, less bleeding. Headache is another one, especially when it's cyclical. Another one that can happen in menopause. It's called the musculoskeletal syndrome of menopause. So we'll start to see frozen shoulder, bursitis out of the blue, and someone who's, you know, didn't injure themselves, but they'll suddenly, you know, like have poor range of motion, and it's due to lack of estrogen.
When I was a Pilates instructor, I saw so many women who had frozen shoulder, and I worked with a physical therapist that I would refer them to. But now it sounds like maybe if we got on the right dose of hormones, frozen shoulder could go away.
Yeah, it could. When I do these things and I'm listening to myself talk, it makes it sound like hormones are like these magic molecules, right, that cure everything. And I do kind of think that they're magical and they are super helpful, but there does need to be some kind of foundation. So like for you, most likely because of your history, your patients were fairly healthy, at least with respect to movement, right? They were doing physical, personal training, they were doing Pilates. And so at least they had that part. So that foundation was there. But you also have to have a good foundation of diet, right? You have to have a good diet. If you're eating processed foods and drinking alcohol every night, there's no amount of hormone that's going to fix the dysfunction that comes with that kind of diet. if you're super stressed out and you're not willing to do like therapy or meditation or breath work or other mindfulness type practices, then there's nothing I can do to help your brain. In terms of, yes, some of the hormones will make you feel a little better, but they're not going to cure everything. So there does have to be a foundation. You need, all of these things are important. And when I sit down with my patients, I talk about all of those stuff. Sleep hygiene, so great, I give you progesterone, but if your sleep is all over the place and you force yourself to stay up till 2 one night and then you go to bed at 8 p.m. the next night and then the next night it's 10 p.m., like your body isn't going to know what to do. So having a routine with respect to sleep is really important. If sleep is or fatigue is one of the issues that you're having, or even anxiety, because poor sleep can lead to that. So it's a multifactorial thing. Hormones can be magical, but they are not everything.
They're kind of like the icing on the cake, right? You can't put icing on anything if you haven't baked a cake.
Right. Exactly. You have to have a foundation.
One of the symptoms that I experienced that I couldn't get to the root cause of was itchy ears. I was itching my ears, like I couldn't stop.
Mm-hmm.
And then I realized from, I think it was Carrie Jones, Dr. Carrie Jones said, you have receptors everywhere and you can start to experience itchy ears and phantom smells. And it seems like if anything goes wrong in a woman's life, maybe it's just a perimenopause symptom.
Yeah. Yeah, I know. It does. I mean, especially nowadays, because it's becoming more and more talked about more and more on like social media, and even with concierge doctors becoming more aware and training themselves. We're starting to hear like perimenopause and like everywhere. At least that's how it feels to me. But it's true. I mean, it affects every single woman. Like, not, there is no woman who will escape it. So, I mean, I guess some weird genetic disorder that you were born without ovaries and a uterus to begin with, then maybe you wouldn't go through it. You wouldn't know any difference. But yeah, no women will escape perimenopause or menopause. Every single woman will go through it. And the other thing to be said is that menopause doesn't stop, right? It doesn't mean like you stop, your period stops, right? Say January of this year, you didn't have a period and you haven't had one since. And then you get to January of next year and suddenly you're done with menopause. No, that's not how it works. You're in menopause the rest of your life. They just call it postmenopause. So those changes that occur during menopause continue to affect your body for the rest of your life, unless you do things to help support your body function better. So, sometimes when I see women in my office and they're like 75 and I'll say, oh, so when was your last period? And they're like, oh, I went through that years ago. I'm done. Like, nope, you're not. It's still affecting you. So they don't understand like why they would, oh, I did all of that. Why do I need this? I'm like, well, you want to protect your body.
Oh, I like that. And I like the picture that you paint and so much knowledge that you're sharing today. And speaking of social media, I feel like perimenopause is kind of painted as this horrible thing, so many symptoms, you're going to go crazy and not sleep well. And I saw this post that talked about it as a rebirth. You're going through this change where eventually you won't have any more F's to give and you'll sleep well and things will start to calm down. And I feel like that was such a beautiful way to reframe it.
Yeah, I don't think that it has to be a horrible place. I think we just need to start training women to learn how to support themselves through this transition. Because a lot of, like, I don't know about you, but a lot of the people that I follow on social media, they are stronger after menopause than they were in their younger years. And as long as they are doing the things to help support their body to be stronger, it's pretty remarkable. And it's like a lot of women are feeling like because we've gone through those developmental stages. We are no longer as insecure and unsure of ourselves. We kind of figure out what it is we want and what we want to do. And so mentally we're very strong and focused on what we want moving forward, whether that be in relationships or work or family or business and hobbies, we have a direction. And so as long as we can support those physiologic systems that help to support our brain and our motivation and our focus, we are unstoppable. I think that it can be a very powerful phase of our life, not something that's detrimental.
We can become the best versions of ourselves.
Absolutely.
Earlier, you had mentioned concierge medicine. And I feel
Yes.
like everything that we've spoke about today, you're not going to find if you go to a regular allopathic doctor. Maybe tip of the iceberg. They might know something. I don't know if they'll prescribe hormones. But can you give us a bit of insight of where you work?
Sure. So I would say, so my practice, Halcyon Health, is a concierge hormone replacement and wellness practice. And the key thing with that, because I worked in traditional insurance-based practices the majority of my career, and I basically got anywhere from 5 to 15 minutes with a patient to learn who they were, what was going on with them, figure out their history, and then figure out what to do from there. And then educate them. And I have, 5 minutes to do all of that. And it's just not possible. There is so much nuance. I mean, with whatever disease process, right? Like, you talk about telling someone they have cancer. You think I can tell them that and have any kind of empathy within 5 minutes? No. So, it's not a model to allow for this discussion that I was talking about when it comes to symptom management and all of the nuances that are associated with hormones. So I decided that when I started this practice that it needed to be concierge, because I wanted to give the time to each individual, the amount of time that they deserved in order to tell me what their story is, kind of what their background is, how they came to find me, how they came to like have all of these symptoms and problems that they're experiencing now, what their family history is, what kinds of things they're prone to, all of those things. So it's super important to be able to have the time to sit and have this conversation and develop a relationship and a partnership with that individual, because I cannot help you unless you tell me what's going on with you. It's all a guessing game. So one of the things that my sister and I found to be extremely important was direct access to me throughout this process. So when I start, because like I was telling you, I don't know who's going to be sensitive to progesterone, who's not, who's going to take it like it's like a placebo, and others who are going to have all these side effects. I don't know who's going to be who. And so do I want to give them a pill and then tell them, okay, I'll see you in 3 months. And then meanwhile, they're confused, they're uncomfortable, they don't feel good, and they just have to wait until their next appointment for there to be some kind of adjustment. I don't think that that's right. And so with this model, the patients are able to have direct access to me. So in the moment when they start to feel that way, it's like, okay, well, let's make some adjustments. Maybe we need to lower the dose. Maybe we need to increase the dose. Maybe we need to stop it for now. That way it can happen in real time. And the patients then are feeling heard, for one, and getting the results that they're looking for in a timely fashion without it being protracted for long periods of time. So that's one of the key things that I think is important to concierge medicine. It's not just like I'm at their beck and call. It's that they have access to me when they want it. Some months they might not talk to me once. Other months they might talk to me multiple times. But it's when they need it, and they need that support and reassurance or extra explanation about what's happening in their life, what other things, outside factors that I wasn't maybe aware of that could be impacting how they're responding to their regimen. So I think that that's important. The other thing too is that there's a lot of things that you cannot do, or it's very difficult to do under the purview of insurance. It's like being under, someone's thumb all the time, telling you, yes, you can, no, you can't. And access to things becomes very difficult. I'm able to give my patients an extreme discount for their labs because they pay cash. I'm able to give them my time because they pay cash. There's so many things that I'm capable of doing because I'm able to take insurance out of the picture. So that's part of it, concierge medicine, and why I think it's so important, especially when it comes to hormone care.
I can hear the passion in your voice. And out of all the questions that I asked you today, I think that was the one that you spent the most time answering. And I like that you said it's a partnership and you want to help work with the person rather than just give them something and send them on their way. It's really refreshing that
Yeah.
PAs like you exist, that you're opening your own clinic, and that you're really wanting to help people. I love that you're doing that. Do you take telehealth appointments?
Yeah, I do. Both telehealth and in person, if that's what a patient wants. And if I have patients from out of state, the way the laws work here in Nevada is, and in most states, is that as long as you come and establish with me in person at least once a year, I can have a telehealth appointment with you anywhere. So you can come see me, come visit Las Vegas, come see me, have an appointment, and then every other appointment and communication after that can be through telephone or telemedicine.
That's so impactful. Rachel, there was one question that I didn't ask you because, as good as hormones sound, I'm really curious to learn. Once you start taking them, do you have to take them for life?
No, you don't. But it's kind of one of those things. Do you want to feel good the rest of your life? I do. So I'm going to take mine the rest of my life. And, like I said, so many of these things provide benefit and protection. The minute you stop, your body isn't making these things anymore. So the minute you stop, your body no longer is going to have it. So then it's going to recede just like it would around menopause. And what's crazy is like patients who had really horrible hot flashes and get put on estrogen or whatever, and they do really great. And then their doctor, like when they're 65, tells them, oh, you got to wean yourself off of that. And then their hot flashes come back. And they're like, but it's been 15 years. Why am I having hot flashes again? And it's like, well, you were giving yourself hormone. The hot flashes are your body kind of like alarm going off saying like, hey, I'm out of this fuel. I need it. And so it's going to happen again. So I'm hoping that I will be able to avoid that in my life. So that's my plan. And that's what I recommend for my patients too.
Yes, you and me both. Rachel, I have taken away so many nuggets of wisdom today. I didn't know that testosterone could help you sleep. It was really important to hear that if you're taking estrogen, you need to take progesterone with it, different timings, how to optimize your hormones. But as we wrap up this podcast, I ask all my guests the same closing question, which is, what haven't I asked you that you'd like my listeners to know?
I think you went through everything. Surprisingly, I don't think there's one thing that I haven't talked about. Oh, there is one thing. So I was just thinking about this. We talk so much about our sex hormones and how important those are, but there's other hormones in our body that are just as important. One of them being thyroid. Thyroid hormone is hugely important for us, both men and women. And in women, again, it's often dismissed, like those symptoms of fatigue and weight gain. Most doctors don't believe patients when they say, I have a strict diet, I exercise every day, especially if they weigh, 250 pounds. They will look at them and just not trust what they're telling them. And so they'll have all of the symptoms of low thyroid function, but their labs will come back normal. And so the doctors will not provide them with any kind of support with respect to thyroid hormone. So just like progesterone, I was mentioning earlier, how you were making progesterone. If they checked your levels were probably fine, but you had all of these symptoms of not enough. And so they gave you progesterone and you felt better. So why do we treat thyroid any different? And it is just as important for our overall well-being and function as those sex hormones. So don't forget about some of the other hormones that we have in our body and how important those are, just as much as those sex hormones are.
Ooh, well, I feel like that's kind of like a teaser for the next episode. We'll have to talk about thyroid, weight gain, weight loss, and insulin resistance, and what to do as we gracefully age.
Absolutely. I'm here for it.
Rachel, please tell my listeners where they can go to find out more about you.
You can find us on Instagram at halcyon.health. You can also find us on our website at halcyonoptimized.com. And you can find us on Facebook as Halcyon Health.
Well, we will be sure to point listeners in the right direction. Rachel, thank you so much for your time today.
Absolutely. Thank you, Ashley.
Thank you so much for listening today. A quick shout out on Instagram or sharing this podcast with a friend can make a positive difference. If you're listening on Spotify, Apple Podcasts, or watching on YouTube, a great way to support the show is by leaving me a review. You can also support my work by using any of the affiliate links in my show notes or by visiting my website, ashleydaily.com. This podcast is presented for educational and exploratory purposes only. The published content is not intended to be used for diagnosing or treating any illnesses, diseases, or disorders. Those responsible for this show disclaim any responsibility for any possible adverse effects from the use of this information presented by myself or my guests. Please consult with your healthcare provider before using any products or services referenced in this podcast. The content here is for informational purposes only. Episodes on the Welcome to Wellness podcast may at times cover sensitive topics, including but not limited to depression, suicide, 5G, nootropics, circumcision, birth control, the Women's Health Initiative, the use of plants medicine, abortion, geoengineering, terrorism, gender, AI, sex, drugs, and rock and roll. You are advised to refrain from listening to this podcast if you are likely to be offended or adversely impacted by any of these topics. However, if these topics interest you, you just may have found your tribe. The information or opinions expressed on the Welcome to Wellness show are solely the views of the individuals involved and by no means represent absolute facts. Opinions expressed by the host and the guests can change at any time. The views of my guests are solely their views, and the Welcome to Wellness show does not accept responsibility for them. Any action you take based on the information contained within this show is strictly at your own risk. The Welcome to Wellness host, Ashley Daly, will not be liable for any losses or damages in connection with the use of this podcast. You should take all necessary steps to ascertain the information you receive in this podcast is correct and has been verified. None of the guests or contributors on the Welcome to Wellness podcast will be responsible for your use of the information contained therein. Under no circumstances will the Welcome to Wellness show or my affiliates, partners, suppliers, licenses, or guests appearing on the show be liable for any direct or indirect consequences or damages arising from your ability or inability to access this podcast. All intellectual property rights belong to me, Ashley Daly, and include but are not limited to the copyright and any other rights in the design. You are permitted to use the Welcome to Wellness podcast for personal use but not commercial use without a license. You may not make recordings. If you breach these terms, you lose the right to access the Welcome to Wellness podcast, and you must destroy or return any copies of the recordings you've made. Guests on the Welcome to Wellness podcast may at times provide information on or read extracts from third-party copyrighted work. The Welcome to Wellness podcast does not provide any medical or professional advice within these episodes. If you take any action or inaction as a result of the content you consume from the Welcome to Wellness podcast, this is based solely on your decision, and the Welcome to Wellness podcast, Ashley Daly, and my guests cannot be held responsible or liable for any of the consequences of such action or inaction. Thank you for listening.